Hi folks, this is Dr.Kameapalli uh, discussing the topic about fecal bacteriotherapy. The idea of this presentation is to try to see if I can do a patient-centered education material regarding fecal bacteriotherapy and also try to see if the yuck factor can be overcome regarding this, and also to see if I can uh, come up with the data that we have collected over the last 3 to 4 years that we have done fecal bacteriotherapy and discussed that also. This is part patient educational material, and also this presentation needs to be taken in the view of the in the view that it is not something that has to be replicated at home, but it has to be the guide for any other physicians who would want to pursue this down the road in their centers. And I don't have much of any disclosures or conflicts regarding this. What is C-Difficile? It's a disease caused by bacteria that can infect large bowel and cause colitis. Intestinal tract of normal people contains normal flora that helps protect us from infection. Clostridium difficile is in our food chain, but then we can get colonized by it. But sometimes when you have overburden of it after antibiotics kill the good bacteria, allowing the Clostridium difficile to multiply, then the toxins are released, and that causes the damage of the intestinal wall and cause the diarrhea and complications associated with it. And Clostridium difficile is a spore-forming organism that is gram-positive anaerobic bacillus, and it produces toxins, toxin A, toxin B, and toxin AB. And these toxins cause the abdominal cramping and abdominal distension and diarrhea, causing the dehydration and toxic megacolon and sepsis and even death. And unfortunately, the problem with Clostridium difficile is there is a 35% chance of reoccurrence of this happening over time, and that causes this overall problems with C. difficile infection to be a perpetuating problem if not appropriately treated. It is normally easily contaminating the environment that the patient is living in, like on the surfaces of the table, doorknobs, and it spread via the contact. And hand washing is a very much important tool in this, including making sure that nice soap and water, lathering of the hands is the key, not alcohol hand sanitizer. Um, and C. difficile infection has become more prominent because of the antibiotic therapy that is being used, and also it has become more difficult to treat. It is more likely to recur after initial treatment, and it has become more prominent in the community also, and there is a 25 to 40% chance of reoccurrence of C. difficile. The risk factors include current or recent hospitalization, and 20% of the people hospitalized can have it, and 50% of the people with long-term hospital stays, like nursing home stay, these people end up being carriers, and exposure to them also increases one's chance of being infected. And these people who are carriers mostly do not have any symptoms. The risk factors of C. difficile include recent antibiotic therapy, and as the age increases, the risk factor of infection increases almost 10 times, and this is because of severe weakened immune system, and also other medical conditions that have immunosuppressing effect on the overall clinical status will be a problem. And also people with recent infection with C. difficile are at risk. Mostly the symptoms are because of recent history of antibiotic therapy, and sometimes these symptoms occur after 5 to 10 days of antibiotic therapy has been done, or sometimes it may take up to 10 weeks after antibiotic therapy for this C. difficile symptoms to occur. And like we talked earlier, the severity can vary with some people having severe infections and some people being carriers. These carriers can spread infection to other people also. Most common symptoms are diarrhea that's more than 3 to 4 times to 10 to 20 times sometimes, and this is associated with abdominal cramping. And more severe cases, colon becomes inflamed and there is raw patch of tissues that is there in the intestine, which is large intestine, and it's called pseudomembrane, and with an inflamed colon it is called pseudomembranous colitis. In pseudomembranous colitis, the diarrhea can be up to 15 times to 20 times too, and also it is bloody with pus in the stool and dehydration and fever, loss of appetite. At which point staying at home might not be the greatest thing to do, and medical care has to be sought as soon as possible. People can have life-threatening problems, including abdominal distension, abdominal perforation, and potentially leading to severe sepsis with organ failure and even death. Diagnosis in the past used to be very hard, but with the PCR technology now, the diagnosis has become a lot more easier. In the past, the stool used to be tested for toxin, and sometimes these tests were not available for days. And but now with the PCR technology, these results are available faster. One has to have high suspicion for this infection, given the overall picture in the context of use of antibiotic therapy. Most important thing is to stop antibiotic therapy, not treat quote-unquote UTI with different antibiotics therapies that are very much the key for causing the C. difficile. If antibiotic is necessary, the healthcare provider may choose antibiotics that are less likely to allow C. difficile to propagate. You have to finish the antibiotic course once the PO antibiotic therapy for C. difficile is started, usually 10 to 14 days, but nowadays this treatment is being prolonged also. There are probiotics that are used. Healthy microorganisms with yeast are being used, and there are several suggested benefits of this, but in severely ill patients, obviously hydration, including oral and intravenous hydration, is very much important. In people who have failed all these problems, may end up having a surgery to remove the infected colon to prevent life-threatening illness, including death. Now, supportive treatment, like we talked about with hydration, is very much important, and fluid replacement is with appropriate electrolyte solutions is very much important also. And if it is a replacement of fluids in children, it has to be very much meticulously taken care of and handled very much appropriately. One way to judge dehydration is the color of the urine and how often a person urinates. Urine should be light yellow and nearly colorless to say that you have been well hydrated. Well-hydrated person should pass urine every 3 to 5 hours. And if the urine becomes dark, then one needs to increase the fluid electrolyte intake. And obviously, if a patient becomes very much dehydrated, patients have to present to their healthcare provider. And there is no particular food group that is recommended, but adequate nutrition is very important, and use of boiled starches and cereal and potato noodles, rice, wheat and oats, and crackers, banana, soup, and boiled vegetables may also be eaten. And coming to the prevention of C. difficile, it's very uncommon to occur in patients who are not taking antibiotics, but there have been reported cases where people have not taken antibiotics, but C. difficile has occurred in them. And it is important that once people get infected, they need to try to prevent the spread of this bacteria, as they can reinfect themselves also. They need to wash their hands with soap and water, and after every bowel movement, they are better off taking a good shower, and also make sure that the hand hygiene is very much meticulously taken care of. Hand washing is an effective way to prevent the spread of C. difficile, and also soap and water rubbing together for 15 to 30 seconds, and paying special attention to the finger nails, and in between the fingers is very much important. And also one should not hesitate to even educate the healthcare providers and encourage them to be compliant with hand washing with soap and water instead of alcohol hand sanitizers between patients, if C. difficile is the treatment that they have been. C. difficile is the patient organism that is being treated. Is alcohol, as this is because alcohol-based hand rubs are less effective against the C. difficile spores, and this is not recommended for preventing the spread of this infection. Artificial fingernails is one other problem, and the artificial fingernails are not permitted by the healthcare providers for exactly this reason, to be worn in the healthcare setting. And patients are generally placed under contact precautions to prevent the patient's infection from being spread to the other patients, as this is a process of preventing the organism from being spread to other vulnerable patients. And everyone who's washing or leaving the room must be wearing gown and gloves, and wash their hands with soap and water instead of alcohol hand sanitizer to prevent C. difficile spread. Now, recurrence is a problem that we're going to talk about, and this can happen after the symptoms have resolved in 25 to 40% of the patients. This can happen because of reinfection, of not good hygiene, or also presence of spores in the patient's own environment. It could be in recurrence caused by the original infecting strain or by a different strain. Approximately 50% of the patients have reinfection rather than recurrence, and it's hard to tell the difference between both of them. And most recurrences occur within 1 to 2 weeks after discontinuing the antibiotic therapy with flagyl or vancomycin, which is treatments that are mostly used in this setting. And this can rarely occur in up to 2 or 3 months later also. And people with first recurrence have a chance increase up to 50 to 65% of additional episodes. And first episode is normally treated as of recurrence is normally treated as an initial infection, but subsequent episodes treatment is given longer, and there are new antibiotics including fidaxomicin and long-term use of vancomycin, and also there are newer therapies that are being evaluated for further interventions. Now, fecal bacteriotherapy is considered in certain situations when they have multiple reoccurrences, and this is one of the interventions that we have been following in people who have had at least 2 or 3 recurrences, and at which point they are not wanting this to reoccur any further. And after further multiple education meetings with the patient, fecal bacteriotherapy either by NG tube or by enema, or that is nasogastric tube application into the duodenum, or via the enema is the way in which fecal bacteriotherapy is mostly done. But there are now new approaches using possibly a pill that might be used down the road for fecal bacteriotherapy also. But those are techniques that are slowly developing down the road. The reasons for fecal bacteriotherapy include failed regular course of treatments, including flagell treatment, vancomycin treatment, and also fidaxomicin treatment, and also refractory C. difficile colitis, where all these treatments have failed. And also once there is a newer strain of C. difficile that can be causing refractory infection, not amenable to regular therapy. Fecal bacteriotherapy is also called stool transplant, and this has been shown to have a greater cure rate than antibiotic therapy, and this involves infusion of bacterial flora acquired from a feces of a healthy donor, and this reverses the bacterial imbalance responsible for this recurrence of infection. Now, stool from the donor is collected mostly. It is a close relative who is tested for a wide array of pathogens, and these are transmissible infections that are normally screened prior to the patient being given this this material via the nasogastric tube, colonoscopy, or retention enema. And this procedure replaces healthy colonic flora and reestablishes resistance to colonization by C. difficile. There are many reasons why this fecal bacteriotherapy is not being the first ray of treatment because of the number one, patient and provider resistance because of perceived unpleasantness of the procedure, and the repugnance that is associated with this procedure must be overcome before proceeding with this often effective therapy. Otherwise, patient the appropriate patient is selected, and steps followed in fecal bacteriotherapy include finding the donor and testing the donor for these appropriate tests, and also nasogastric tube placement, and also preparation of fecal effluent and administration with the appropriate schedule, and also follow-up. These are the steps that we follow. And after testing the stool and blood of the donor for transmissible infection, the stool donor is instructed to follow particular dietary protocol, including not eating the nuts, and also educated to be not on any antibiotic therapy, at least for the last month prior to the fecal bacteriotherapy. That is, the donor is better off not being on any antibiotic therapy as much as possible for at least 2 to 4 weeks prior to this procedure, and before the donor gives the specimen. Procedure is mostly done in the hospital, either in the outpatient department and rarely in the inpatient department. And patient is educated to continue the antibiotic therapy until the morning of the procedure. That is, the patient is educated to take his PO antibiotic therapy, mostly vancomycin or any other treatments that are being done only for C. difficile until the morning of the procedure. And duo tube, which is a small tube that is placed through the NG through the nasogastric pathway is placed in the NG tube into the stomach, and then radiologically it is guided into the duodenum, and position is confirmed, and tube is locked at the nose area to prevent it from being dislodged out. Now, once the fecal specimen is gotten, saline is poured into it, and it is easily blenderized with a spatula. Initially, we thought of using a blender to blend it, but that was thought to be cumbersome, whereas all we needed was a fecal effluent. So try to use a filtering with 3 to 4 layers of 4x4 gauze, and fecal effluent is then taken off the pot, slowly poured into the specimen cup via the gauze. Once this is done, the fecal effluent is filtered, and this is done using 2 or 3 gauzes, and the specimen is obtained in the cup. 4 of these cups are prepared, and these 3 are the cups that the patient takes, and the first cup of this one, which is almost around 120 ml, is given as a one-time infusion in the outpatient department by the doctor, and further instruction is given to the family members. Once the fecal effluent has been prepared, the patient who has by then had a nasal tube that passes into the duodenum, that is the small intestine, is brought into the outpatient department from radiology after the tube has been confirmed to be in position in the small intestine, that is the duodenum, and the fecal effluent is instilled into the bigger opening of the nasal duodenal tube, and patient's family members are educated when this procedure is being done, and also we make sure that all their questions, concerns, issues are addressed, and also we make sure that they understand that there should not be any resistance when this procedure is done, and also the chances that there might be tube kinking or the tube coming out were also educated, and also made sure that the whole procedure is explained to the family member who is going to do this procedure at home. And once they are comfortable, then the family members are given the supplies to do this procedure at home. After the procedure is done, we make sure that the family is educated regarding any questions, and they are again and again educated to make sure that they understand that they should not force the fecal effluent into the tubing, and there has to be no resistance. And after they instill 60 ml every 8 hours for 48 hours, then an appointment is made also to have the NG tube removed, and they are again educated to avoid antibiotics, and also educated to call if there is any questions or concerns, and also after the therapy is done, the NG tube is removed, and probiotics are continued for 3 months, and also we also make sure that antibiotics are avoided for 6 months to a year. And this fecal bacteriotherapy is being done in our center since around 2009, and we have done around 47 patients by 9/4/2013, and this procedure was done since around 2009, and 7 patients of these were acute patients. So these were done in dire need situation only, when there was no other option, and either the patient was dying or the surgeon did not want to do anything further, and in that option only we did do acute patient treatments, and one of the patients did go on to go into hospice. So only 5 of the 6 patients were treated, and they did go on to heal with the C-diff therapy and fecal bacteriotherapy, which helped really recolonize them. That is the judgment that we had as to fecal bacteriotherapy having contributed to the survival of those 6 patients. And one should note that FDA recently had suggested this be done under institution of new drug guidance, but they did go back on the ruling because of the need that is there in the clinical scenario, and also it was suggested that those patients who are having any problems be reported back to FDA. There is some data collection process that is being set up by FDA for that. But we have been collecting data of our fecal bacteriotherapy patients since 2009, and in the recurrent refractory patients that we have treated, 40 of the 40 of them, 39 did go on to get cured. That is 98% success rate. And the one patient that did not get cured by fecal bacteriotherapy for recurrent refractory C. difficile was a patient who did not have any related donors to give any stool, and one person that gave her the stool was an unrelated donor. So I'm not sure if that should be included in this data, but that's what was done, and that's being reported here. What we have decided was secondary to this success and also repugnance that is associated with fecal bacteriotherapy. We decided to take a patient's perspective and to find out how effective they were. And at the time of the retrospective study via the survey, we had done 34 patients with fecal bacteriotherapy, and 28 of 34 were deemed appropriate for the proposed survey, and that is, they are alive and cognitively able to answer the questions of the survey. And we did found out that of the 28 patients, 20 patients returned the survey with a survey return rate of 71%, and outcomes that were noted for the study included improved symptoms and long-term follow-up, and also patient satisfaction with the procedure. And of note, you see that there is a female to male ratio. We did do a lot more female to male patients, and these were all comers, and there was no selection process in it. It was a retrospective review, and most of the procedures were done outpatient. And the short-term survey results include symptoms of abdominal pain and improvement, and also the nausea that has improved, and also stool per day that has improved. And over the period, this has been shown that by 10 days, patient had almost less than 4 stools, and there has been a greater satisfaction with short-term results of this patient survey. And long-term results at 3 to 6 months post-survey, patient had 85% had no diarrhea, and 3 to 6 months post-survey, 85% had no nausea, and no abdominal cramps in 90% of them, and 95% of them continued their probiotics for at least 3 months post-procedure. Now, the patient satisfaction, this is an amazing part of the whole survey, where patients were satisfied with the costs of the procedure, which at this point there are no codes available for this procedure, and essentially the costs that are associated with it is that is the outpatient and radiological procedures, and also testing costs for the donor stool that vary with different labs, and also the score of 9.9 out of 10 for the satisfaction with the facility providing the procedure, and also 9.6 out of a Likert scale of 10 for overall results, and also 9.9 for the likelihood of recommending the family members to undergo this procedure if they do get C. difficile is a hallmark of this retrospective survey. And in conclusion, a patient who have undergone fecal bacteriotherapy understand and perceive that this is an effective option, and abdominal pain, nausea, and stool frequency has improved, and all surveyed patients reported high satisfaction for the outcomes. And existing data suggests that further consideration by government and appropriate payers sources regarding fecal bacteriotherapy as a legitimate medical procedure that helps with and patients who have limited options of treatment might help hasten the procedure being available for people who are suffering and who have no other options of treatment. One should understand that this procedure is approved at this, is being done at this point only for people with C. difficile. But one should understand that what I think we are doing by fecal bacteriotherapy is re-establishing the balance of what happens with human bacterial microbiome. So as it is, we human beings are made of more bacteria than the humans. So it is the human microbiome which is the forgotten organ, and it is really the genome of the human body is made up of 10% of your cells and 90% of the bacteria that that one carries on the skin, in the mouth, in the gut, in the intestine, and it is not one who thinks of themselves as themselves, but so there are trillions and trillions of cells that make us who we are, and the microbiome is unique to every part of the body. There are different bacteria, including colon having different bacteria, which are mostly Firmicutes and Bacteroides. But skin has a different bacteria, and mouth and genital areas have different bacteria. And as one should know, there is a NIH project with Human Microbiome Project, and it is being evaluated for its role in overall clinical status, and also this is a bigger project that hopefully will produce more results. And by these studies, it was noted that colonic insertion of stool from conventional rat to a germ-free rat produces rats with diabetes, hyperlipidemia, and hypertension. And also it is shown that brief course of antibiotic changes the colonic microbiome permanently. And also it is shown that stool transplant from healthy donors to patients with C. difficile restores the sustained health. And also patients who have been noted to be exposed to antibiotics in the early childhood are shown to have some issues with Crohn's disease. And one should know that Helicobacter pylori is associated with peptic ulcer, and also lymphoma like changes and esophagitis. And overall, one should understand that human microbiome has greater role in functioning, and also there possibly is greater interventions that are to be pursued down the road to figure out what the role of human microbiome is in other aspects of healing. And hopefully this was educational, and this whole presentation needs to be taken in the context of the clinical scenario, and this is only for educational purposes and only for learning purposes. Please use this as educational tool, and also make sure that you follow your physician's guidance. And if you have any further questions, please do not hesitate to call my office or visit our website at www.nobadbugs.com. Thank you very much and have a great day.